What first drew you into orthopaedic surgery, and how did you involve a special interest in feline orthopedics?
So with orthopedic surgery, I enjoy all types of surgery, not just orthopedics, but my interest came from doing a PhD which specialised on the cat carpus or the cat wrist joint. And I was really interested because there wasn't a lot of literature written. And so I thought there was a really big gap that would be good to fill, because cats are kind of silent sufferers. When they're in pain, you don't know. And so I'm hoping to build the database on what we have in cat research to eventually improve their quality of life. I have my own cat, Prince, who is 16 years old, and he's relevant to all of this as well because I got him when I was a new grad. He had a green stick tibial fracture and was abandoned, so I kind of adopted him from the clinic I was at the time, and just crate rested him. But he's got hip dysplasia, he's got patellar luxation, so he has some orthopedic issues that I'm trying to manage at the moment, and that's helped to motivate my interest in cat orthopedics.
Very nice. The pleasure of watching one of your talks at, I think, Vet Expo, and you had some really great videos on cats with pain.
Yes.
And if you were talking to me as a referring vet on a phone, what would be some of the tips you would say, could this be orthopedic, if they're ringing for advice?
I guess with cats that have orthopedic pain, I've done a few conference talks, but generally the things that you see will be hesitation in doing normal activities or not doing the normal activities to the same degree, which is very different compared to dogs. So, for example, they may hesitate before they jump down. They may not jump to the same height. So when my cat was, maybe 5 years old, he could jump on the kitchen counter. Now he can't jump as high as the bed. The other thing is that they may be a bit more lethargic, less interactive with their owners, a bit more unwilling to play. It's quite unusual to actually see a cat with lameness, and if they are lame, it means that there's a serious problem and they're really sore, so it should be investigated. But even if they're doing things a little bit abnormally, for a referring vet, they can look at something called the musculoskeletal pain index, and that objectively tells us how painful a cat is compared to one that's normal and doing everyday activities in the same way.
The index work, I genuinely don't know it. I need to know.
So it's I think it's available on the North Carolina State University website. But basically, there's a scoring system that you assign to each activity that a cat does. So for example, how easily can they jump up onto a chair? And the scoring system basically looks at how easily they do these activities. I don't remember offhand, but it is readily available, and it helps you at the end to have a number, I believe, out of 100 to determine how sore your cat may be.
Mm-hmm.
Yeah.
So if I'm bringing my cat to you and I said, something's wrong, I think he's limping a little, I don't even know which leg, which could be the truth.
Yes.
What are some of the questions you would ask the owner in that instance, or how would you conduct the consult for that owner?
So probably the most useful thing is to get the client to collect some videos at home before the consultation if possible, because sometimes the cat will, you'll assess the cat, take it out of its box, and it'll just be in a little ball. It won't want to walk around the consultation room. So I try to get as much information from the owner as possible. I open the carrier when they come into the consult, and I start to get a history about normal activities that the cat can and can't do. While I'm doing that, I'll actually watch the cat walking around the consultation room. Sometimes it helps to see if they can jump up onto a chair, for example, or how they navigate those things. And then after I've got a full history and have a vague idea of where they're lame based on watching them walk from a distance, I'll actually do a close-up exam. So I'll pop them on the table, have the client help to handle them as well, and then do a full exam. With some cats, if they're a little bit grumpy or scared in consult, it helps to use something like gabapentin, for example, to help take the edge off and make them a bit more sedate. Or we can give them licky treats so they're distracted during the examination.
Some of the most common orthopaedic conditions you see in cats that referring vets might underestimate or miss.
So I guess fractures are really obvious. To be honest, we see those the most commonly because the cat's non-weight bearing, there's been a trauma, and it's quite clear that there's a problem. But the other conditions that we're recognising more in cats would be, for example, medial humeral epicondylitis, which is basically like golfer's elbow in people, where there's compression or squashing of the ulnar nerve. So that's something that's newly discovered that can cause neural pain. There's also hip dysplasia, patellar luxation, and sometimes there can be various carpal and tarsal injuries. So I think generally I don't see many cats for normal orthopedic issues because they're quite uncommonly detected. But my feeling is that they are as common as they are in dogs, except perhaps we're just not perceiving or diagnosing them very commonly.
Your imaging of choice, if you had your way, if it was are we leaning on X-ray, CT, MRI, ultrasound?
So it depends on the issue. If, for example, it's something like medial humeral epicondylitis, we start with X-rays or radiographs, and sometimes we'll see mineralisation around the tendons of the elbow. But if that's not helpful, then ultrasound or MRI can be beneficial. With ultrasound, I'm working on some research to try to develop a protocol that maybe we can use on cats in the future, because at the moment nothing's published. With regards to hip dysplasia, femoral capital physeal fractures, patellar luxation, carpal tarsal injuries, we normally start with X-rays. And then if we don't have enough of an answer, we may recommend cross-sectional imaging with a CT scan, which is a 3D X-ray.
With the sonographers here, they've obviously got a lot of musculoskeletal experience, which is nice.
do.
And we've got that new Fandangle ultrasound.
Yep.
Have they done any for you?
They have. So I did have a case maybe 1.5 to 2 years ago here of a cat with medial humeral epicondylitis. And the benefit of our sonographers is they have human experience and they know about golfer's elbow. So they were able to give me some advice on how to do the ultrasound. And what we did was that we ultrasounded the elbow in different positions, and that helped to assess if there was always compression of the ulnar nerve. So I thought that was pretty cool. We also use them to help diagnose calcaneal tendon ruptures in cats. So it's been super beneficial having them on the team.
Yeah. Share a bit about your training pathway and any key mentors or experience that shaped your approach.
That's a good question. I basically did most of my study at the University of Sydney Vet Teaching Hospital. So whenever I speak to students, I always say that I never wanted to specialise, I never wanted to go back to uni, I was just happy with getting by. But I worked in GP for a few years and I always really enjoyed surgery. The pathway for me was I worked at the RSPCA, was doing a bit of surgery but not as much orthopaedics as I wanted to. I saw the opportunity arise at the teaching hospital, I think that was around 2013, and I started with a rotating internship, followed the surgeons around, ended up doing a surgical internship from there, a surgical residency, and then my main supervisor was Dr. Laurence Brunel, who has worked here for a while too, and also Professor Ken Johnson. So there were other specialists that had a role in my career, but they were probably the ones that I spent the most time with. And I worked on a PhD with Professor Johnson, and he had this initial idea to look at the cat wrist joint, which I developed into something a bit bigger. I published the PhD with his mentorship later, and then I also passed my board exams. Also received a master's through doing the residency and the clinical program at the university. And I still work there and I mentor and teach interns, residents and students. So I'm really passionate about both teaching and research as well as the clinical work.